Hi, this is Shelley from the Canadian Partnership Against Cancer. Welcome. And Dr. Srigley, would you like to welcome us to the presentation?
I sure will. Good afternoon, everyone. I'm Dr. John Srigley, Pathology Advisor at the Canadian Partnership Against Cancer and a Consultant Pathologist at Trillium Health Partners in Mississauga. On behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I'd like to welcome everyone to today's CAP Cancer Protocol Education session on Lynch Syndrome. This is our 10th year of organizing these sessions, and this will be our 49th session that we've organized over the years. Before I introduce our speaker and we get underway, I'd like to take care of a few housekeeping items. Firstly, the session is being recorded, and a link to the recording will be circulated to all participants via email when it becomes available. Both the live presentation and the recorded presentations are eligible for CME credits. Information for obtaining credits can be found in the session notice. Please note that the CME certificates for each session will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. We have a large number of participants and will not be able to troubleshoot Skype for Business issues as part of this call. If you are experiencing technical difficulties, please call the Skype for Business support line. We encourage you to submit questions at any time during the presentation using the chat feature within Skype. Chat instructions can be found on the session notice. During the question and answer portion of the presentation, a session moderator will pose the submitted questions on your behalf for as long as time permits and in the order in which they appear. In the chat window, please indicate the following information: your institutional name, the name of the individual posing the question, and finally your question. It is now my pleasure to introduce Dr. Aaron Pollett. Dr. Aaron Pollett is the Provincial Head for the Pathology and Laboratory Medicine Program at Cancer Care Ontario. He is an anatomical pathologist and co-director of the Division of Diagnostic Medical Genetics at Mount Sinai Hospital and an associate professor in the Department of Lab Medicine and Pathobiology at the University of Toronto. Aaron has a specialty interest in gastrointestinal pathology and pathology informatics and has a master's degree from the Department of Health Policy Management and Evaluation at the University of Toronto. He is a review pathologist for the Familial Gastrointestinal Cancer Registry and the Ontario Familial Colon Cancer Registry, both tumor-based registries constructed to analyze the genetic basis for gastrointestinal cancers. In his various roles, Dr. Pollett oversees the molecular analysis of solid tumors as well as the development and implementation of molecular biomarkers. So without any further ado, I introduce Dr. Aaron Pollett to give today's talk on Lynch syndrome. Aaron?
Thank you very much, John. And thanks for CPAC and the opportunity to talk about a very timely topic, and that is Lynch syndrome, particularly the role of reflexive mismatch repair immunohistochemistry. For this talk, I'm going to give a bit of an overview, and then I'm going to focus on the approach that we've taken in Ontario with regards to implementing a provincial-wide immunohistochemistry program focused on the identification and picking up patients with Lynch syndrome. I don't have any financial disclosures. I will note that I've been involved with a couple studies that look at Lynch syndrome mismatch repair immunohistochemistry. One of them is sponsored by the Terry Fox Research Institute, the C4 study. That is a pan-Canadian study. And the other one is a more local study looking at endometrial cancer, and that's the LS2 study. So for this talk, I'm going to give a quick introduction just around Lynch syndrome to explain the importance of why we need to identify patients with Lynch syndrome, benefits from identifying the patients early. Because I am talking about Lynch syndrome, it's going to be a little bit of a diversion into the world of microsatellite instability, or MSI. And then I'm going to really focus in on mismatch repair immunohistochemistry. This is going to be a pretty high-level talk. I'm not going to go into some of the ins and outs of actually interpreting immunohistochemistry for mismatch repair. It's one of those things that starts off pretty easy, and then once you start doing a lot of it, you start realizing, hey, this is not quite as easy as we once thought. I'd be happy to discuss some of the fine points of immunohistochemical interpretation at the question period if anybody wants to get into that. I'm then going to talk about the implementation of what's Lynch syndrome, and I put in brackets screening, because we're not really screening, but we're using a tool to try to better predict patients that might have Lynch syndrome so that they can be appropriately referred to genetics. So we'll talk about our approach that we're using here in Ontario. And then I'm going to branch out into some of the other uses for microsatellite instability. The reality is that MSI testing has gone beyond Lynch syndrome, and it's important to understand how the testing that we are doing might impact on the clinical management of patients, and also how clinical requests have to feed back into any sort of Lynch syndrome screening program. And then finally, a few slides on future directions and what's potentially happening in the world of Lynch syndrome and microsatellite instability testing. So Lynch syndrome used to be known as hereditary non-polyposis colon cancer, and this is really an obsolete term. It occasionally does pop up, but I strongly discourage the use, and that's because when we talk about Lynch syndrome, we are really looking at a syndrome that involves multiple cancers, and it's really hard to tell families that have hereditary endometrial cancer or patients with ovarian cancer that they have HNPCC and that they need to have their colon screened when they don't have colon cancer in their family. It's much easier to talk about Lynch syndrome as a overall cancer predisposition syndrome. It is autosomal dominant, and that is that if you look at the hereditary patterns in the family, it follows a dominant pattern, and that is the patient with Lynch syndrome will inherit carry one of the two genes that are associated with mismatch repair, and they have a 50-50 chance of passing on that gene to one of their offspring. So it is, when we talk about cancer syndromes, it is following an autosomal dominant pattern. The key genetic change associated with Lynch syndrome involves the mismatch repair genes, MLH1, MSH2, MSH6, PMS2, and I have EpCAM there. EpCAM is bolded because while it's not specifically involved with the mismatch repair process, it's located very close to MSH2. So patients that have alterations in EpCAM can have inactivation of MSH2 through impacting the promoter region of that gene. So when we talk about the mismatch repair genes, we really talk about the function of 4 key genes, but when it comes to testing for patients with potential Lynch syndrome, there's 5 key genes that are actually being tested for. The way that these genes are involved with genetic repair, as you can see in this schematic, they form 2 sets of dimers that come together, and they look for areas during cell replication where you end up with base pair mismatches that occur. So they are the proofreading mechanism that comes along and says, hey, there's something here that didn't match up, identify it, brings in the appropriate excision mechanism to remove the incorrect base pair, and then resynthesis. So you really need to have functional use of all the mismatch repair genes to ensure that during cell replication you're not incorporating any of these mismatches or errors in replication. So patients with Lynch syndrome do have a loss, or they're carrying an alteration in one of these genes, and then if they end up with a loss of function of another copy of the gene, the mismatch repair function does not work, and they accumulate a host of different errors within the genome. Some of these errors, areas of the genome that are particularly predisposed to problems with DNA synthesis when you've got loss of your mismatch repair mechanism, are areas of what are called microsatellite repeats. So those are areas in the genome where you've got runs of a single nucleotide. They can occur in areas that are non-coding, in which case there's no particular outcome, but there are also areas within key cancer genes that contain areas of microsatellite repeats, areas that will be targeted areas that are predisposed to accumulating mutations if you've got a problem with your mismatch repair apparatus. As a result, patients with Lynch syndrome are at increased risk for cancer and a host of cancers. So the most common cancer, and the one that was originally picked up with Lynch syndrome, was colorectal cancer. And while there are some gender variations depending on which genes are involved, patients with Lynch syndrome will have approximately an 80% lifetime risk of developing colorectal cancer. As you can see, compared to the population risk, 5 to 6%, there is a significant risk for developing colorectal cancer. For women, the risk of developing endometrial cancer runs close to 60%, but you can also see that there's a host of other cancers that are associated with Lynch syndrome. I'll pay particular attention here to the small bowel cancer. So while patients with Lynch syndrome only have a 1 to 4% chance of developing small bowel cancer, the population risk is 0.01%. So this actually represents a 1,000-fold increase in the risk of developing small bowel cancer in patients with Lynch syndrome. And as a result, any patient with small bowel cancer, the possibility of Lynch syndrome should be considered. Because endometrial cancer and colon cancer are common, Lynch syndrome actually accounts for approximately 3 to 5% of all colon and endometrial cancers in North America. As I mentioned, about 80% of patients with Lynch syndrome have a lifetime risk of developing colorectal cancer. The average age for development of cancers in patients with Lynch syndrome is approximately 2 decades earlier than patients with sporadic colorectal cancer. The average age is about 45. And about 60% of women with Lynch syndrome have a lifetime risk of developing endometrial cancer. The average age is again about 15 years younger than the average age for endometrial cancer, and it is about 48. So patients with Lynch syndrome will develop cancers at a younger age. I mentioned before about the underlying genetic mechanism associated with Lynch syndrome. As a result, 80 to 90% of cancers in patients with Lynch syndrome have high-frequency microsatellite instability. I'll pay attention that this is not 100%. What that means is if you have a tumor in a patient with Lynch syndrome, there's not a 100% correlation with the tumor being MSI high, meaning that if you have a tumor, it's microsatellite stable. You cannot exclude Lynch syndrome based on microsatellite status alone. So how do we identify these patients? We've got a identifiable molecular phenotype for patients with Lynch syndrome, and one of the ways that we can pick it up is by looking at microsatellites throughout the genome. There are a number of different panels that can be used. The one that's most commonly used in clinical trials, most commonly used within North America, is the ProMega kit. There's an example of the readout here. The way that the microsatellite or MSI molecular testing works is you look at a number of loci within the genome that contain microsatellites. You compare the normal length of these microsatellites, which is on the left, to the length of the microsatellites, which you can see here on the right. The microsatellite regions within the tumor have different lengths, and that's because as the tumor replicates and these errors develop within these areas of microsatellite repeats, you end up with some cells having different lengths of the microsatellites, hence the name microsatellite instability. So we can actually pick up the tumors that have microsatellite instability using molecular tests. Now, the other thing that makes this so interesting and makes it quite exciting for pathologists is we also have immunohistochemical tests that can pick up the expression of the genes involved. Because this is a gene involved in normal cell operations and proofreading, it should be normally expressed. And here you could see that we've got normal expression for one of the mismatch repair genes. I believe this was MSH2. It's expressed within the tumor on the right-hand side and the normal epithelium on the left, as well as within stromal cells, some lymphocytes, and endothelial cells. So that's what you'd expect to see in a cell that expect to see in a patient that's got normal expression of the particular gene. The abnormal situation is the next one, where you've got a loss of expression for the mismatch repair gene. Here again, I believe this was MSH2, and you've lost expression within the tumor cell. Now, proving the absence is a lot harder than proving the presence of something. So as a result, to interpret the immunohistochemistry when it comes to mismatch repair, you need to have a comparator. The nice thing is, because it is normally expressed in stromal cells, you almost always have some sort of internal control that you can use to ensure that the stain has used. And here you could see normal expression within the stromal cells. Elsewhere on the slide, you had normal expression within epithelium, and you can see we've got clear, and for ease here, I'm going to say 100% loss of expression within the tumor cells. Now, we have also known for a long time that there are a particular phenotype of tumor that had relatively good prognosis, and it was the phenotype associated with tumors that have high frequency microsatellite instability. And we were actually picking this up when it came to the histologic assessment of tumors. The tumors that are MSI high are those large, bulky, right-sided tumors that were often poorly differentiated. They had the pushing border, and an example of an MSI high tumor is given here. You take a look at that tumor, there's nothing here to say that that actually came from of colon origin. It's poorly differentiated, but what's unusual is for such a poorly differentiated tumor, it's got such a nice well-defined border. And you can see here it's also described as a pushing border. There are certain histologic types, such as signet ring cells, which are unusual, or tumors that had multiple morphologies. This particular tumor has a mucinous component as well as a more conventional component, and you could also see that it's got a collection of lymphocytes in the associated stroma, which is somewhat unusual. So we've got an unusual phenotype that was also associated with these tumors that are MSI high. The most characteristic feature that is associated with tumors that are MSI high are tumor infiltrating lymphocytes. An example here is a poorly differentiated tumor, but it's chock full of tumor infiltrating lymphocytes. And you could also be seen with a peritumoral inflammatory reaction. So we've got a morphologic phenotype that can also pick up these tumors that are associated with the molecular phenotype of being MSI high. There are these nomograms that do exist within the literature. I know of at least 2 that are out there that are quite complex, and while I know they're out there, I've actually run across one person that uses them, and they tell me they work really well. So you can put a lot of work in here and try to come up with probabilities of determining if a tumor is MSI high. Certainly in the previous AJC checklists, the importance of identifying tumors that had these morphologic features that could suggest that they were MSI high were actually included within the checklists. And you can see the key features here: the tumor-infiltrating lymphocytes, the peritumoral lymphocytic response, and the tumor subtypes. But the reality is that was dropped from the checklist, and nobody uses the nomograms anymore, and that's because the immunohistochemistry works really, really well. So you can spend a lot of time working on these complicated nomograms and give percentages that the tumor is MSI high, or we could start using immunohistochemistry, and that is certainly the way that the practice has developed. The immunohistochemistry is not 100%, but it works really well for picking up tumors that are MSI high. If you've got good functioning immunohistochemistry, you've got a good control, you're happy with the quality, the chance of a tumor being microsatellite stable, especially for MLH1 and MSH2, is near normal. So it is very specific, highly sensitive for picking up tumors that are MSI high. I will also just, because we are focusing on Lynch syndrome, if you're looking at immunohistochemistry versus MSI for picking up cases with Lynch syndrome, for colorectal cancer, you could certainly argue that both tumors, while they will miss a small percentage, are both equally good for picking up patients with Lynch syndrome. For endometrial cancer, because you do have a higher percentage of some of the less penetrant and less aggressive genes as MSH6, you could actually argue that immunohistochemistry is better at detecting patients with Lynch syndrome. So, a couple notes just about immunohistochemistry. When I showed that diagram and how the apparatus actually worked for detecting areas of mismatch in DNA replication, the genes form these sort of dimers, and they have a dominant pair. So MLH1 is associated with PMS2, MSH2 is associated with MSH6. If MLH1 is lost, because PMS2 no longer has a binding partner, it gets degraded very quickly. Similarly, if MSH2 is lost, MSH6 gets degraded very quickly. Functionally, what that means is if you've lost expression of MLH1, you actually cannot tell if PMS2 is not being made or if it was being made or being degraded. Because carrying two germline mutations within the mismatch repair apparatus is relatively rare, we assume that if you've lost the expression of MLH1 and PMS2, it is because you've lost expression of MLH1, and if you've lost expression of MSH2 and MSH6, it's because of loss of MSH2. To truly determine what's going on, you would have to do more involved molecular investigations. But for all practical purposes, we'll assume that when you've lost MLH1 and PMS2, it's because of lack of MLH1 expression, and if you've lost MSH2 and MSH6, it's because of loss of MSH2. So, a couple other just key points, because they're really important for any center that is looking to incorporate or start doing mismatch repair immunohistochemistry. The abnormal expression is when you've got a very clear difference between the tumor and adjacent normal. So you really have to ensure that you're looking at adjacent normal tissue to the tumor to interpret what's going on with expression. And then again, this is just talking about the apparatus and how it works in pairs with that dominant partner. So We do have clinical tools that will pick up this phenotype of patients associated with Lynch syndrome. We have molecular tools. We have immunohistochemistry tools. We've got some sorts of nomograms. Now, in the past, for identifying patients with Lynch syndrome, it has largely been within the domain of the clinical partners to identify potential patients through family history and risk. So the original risk was from this Amsterdam criteria that was modified 2 decades ago, and the Bethesda criteria that is in common use in certain areas within North America. I mention these two because they are the most common criteria that you will see when it comes to clinical history. The Bethesda criteria is of particular interest to pathologists because the presence of tumor-infiltrating lymphocytes, a lymphocytic reaction, and certain histologic features are actually included within the Bethesda criteria. The Amsterdam criteria is based on family history alone. Now, while these are relatively good at picking up patients that have gene mutation, if patients meet the criteria, they're relatively good at identifying a decent probability that there will be a gene mutation on genetic testing. The sensitivity for both of them is not very good. Now, there are much more involved criteria that is dependent on different regions, and I've included test eligibility criteria for Ontario here just for reference. Of note, this is in 2009, so it's already a decade old, and with our understanding of Lynch syndrome and hereditary cancer syndromes in general, this is already outdated. One of the reasons I do include it here is the fact that in 2009 the criteria were updated so that patients that had abnormal immunohistochemistry, regardless of family history, were actually eligible to be seen by genetic counselors within this province. So we have clinical history tools. The traditional way of identifying patients with Lynch syndrome has been through the identification of multiple generations of cancer, patients being picked up by clinicians, being referred to geneticists, having the family tree, saying, yes, you should be involved. There is a role for pathologists to say, hey, morphologically, this patient has features that make it a increased likelihood that the patient's phenotype fits with a tumor that's MSI high and could be associated with Lynch syndrome. But we know traditionally that relying on family history alone, results in an under-referral of patients. These particular studies are with colorectal cancer, but there's a similar behavior with endometrial cancer, and that you run into, even with clinics that have dedicated interest in this, you will pick up maybe a third to half the patients that should be seen. And what's the risk of not picking up potential families with a Lynch syndrome? When you identify families with, and this is an old paper, hence the name hereditary non-polyposis colon cancer, but you pick up families with Lynch syndrome and drop down to the conclusions that when you've got screening, you halve the risk for colorectal cancer. You prevent colorectal cancer deaths and you decrease mortality in these families. There's no question about that. Identifying the families, getting them into a screening program prevents cancer. So it's very important for picking up the families. You will not pick them up if you rely on clinical history alone, and there are very specific tools for picking up the phenotype associated with Lynch syndrome. This paper is over, well, it's 19 years old, and it's taken us a long time to try to really bring this into practice. In 2005, because of the benefit for identifying patients with Lynch syndrome, getting them screened and preventing cancer, they came out and basically advocated at that time there is a role for screening cancers and identifying patients. So the routine molecular screening of patients with colorectal adenocarcinoma to pick up Lynch syndrome. So that's in 2005. Now, I would say when this came out, a lot of people called me and say, you're going to be inundated with people requesting this molecular testing. It has never happened. So it took a long time, and when we look at screening for Lynch syndrome to actually move into practice, the European Society for Medical Oncology came with guidelines for screening all colorectal cancers in patients under the age of 70, greater than 70 if they have Bethesda criteria, with immunohistochemistry to pick up potential families with Lynch syndrome. Just as an aside, the Bethesda criteria and the histologic features associated with MSI high tumors are really great for picking up sporadic MSI high. The true patients with Lynch, we're better off focusing on the under 70s, patients with family history, and doing immunohistochemistry on the younger patients in general. ASCO endorsed the European Society guidelines in 2014, and in 2017, there's joint guidelines that came out through ASCP, CAP, ASCO, and AMP. And in those guidelines, they recommend doing immunohistochemistry or MSI testing on all colorectal and all endometrial cancers to pick up potential patients with Lynch syndrome. So starting in, well, I've got 2019. In December of 2018, Cancer Care Ontario put forward the initial funding to introduce reflexive immunohistochemistry for all patients under the age of 70 with colorectal cancer or endometrial cancer. So I'm just going to make a quick little side note here about endometrial cancer and the importance of including endometrial cancer in any program that's trying to identify patients with Lynch syndrome. And the reason that I'll do this is because a lot of the initial documentation focused around colorectal cancer. So in women with Lynch syndrome, endometrial cancers, they're sentinel cancer in a little over 50% of patients. Over half the women that do have Lynch syndrome and endometrial cancer will develop a second malignancy. This could be gynecologic in origin, such as ovarian, or colorectal. And the lead time could be, on average, is about 8 years, though you do have a number of patients that will present with synchronous endometrial and colon cancer. So it's very important, and in these women, it's not the endometrial cancer that will necessarily lead to cancer-related death, it's the colon cancer. So by picking up patients with Lynch syndrome based on screening endometrial cancers, you can prevent colon cancer and cancer deaths in these patients. So just taking a step back now, we've got a cancer syndrome that we can identify with a specific molecular phenotype. So how do we put this in practice? Well, the microsatellite instability testing will pick up, like I had mentioned, 80 to 90% of the tumors of patients with Lynch syndrome. When we look at all colorectal cancers that are MSI high, it's about 15 to 20% of all colorectal cancers. When we look at endometrial cancers, about 10 to 30% of all endometrial cancers will be MSI high. This is a lot higher than the percentage of cancers that are associated with Lynch syndrome. So what's going on here? The majority of MSI high is actually secondary to MLH1 promoter methylation. Now, the big ranges that I gave you are from the literature on the likelihood of colorectal cancers and endometrial cancers being MSI high. When we looked back a couple of years at the experience at Mount Sinai Hospital, we found that about 13% of all our colorectal cancers were MSI high, so a little lower than we'd expect. We actually had a higher percentage of Lynch syndrome than you'd expect at about 8%, but we've got a referral bias. When you looked at the Pan-Canadian C4 experience, the Terry Fox Research Initiative funded study, about 14% of all colorectal cancers were MSI high, so really fitting with what's reported in the literature, and about 6% into 6% of them were associated with Lynch syndrome. For endometrial cancers, again, a regional study had about 30% of tumors were MSI high, so a little bit higher than the literature would have originally expected, and a 5% Lynch syndrome rate. So you could see that this is common. The numbers that we see in the literature are reflected in studies both pan-Canadian and regional within Ontario. So if we are looking at trying to pick up the potential families with Lynch syndrome, we know that we've got a tool, so we can do MSI testing. Immunohistochemistry will pick up the vast majority of these. We are going to have a lot of noise because MLH1 promoter methylation is going to be the bulk of tumors that are MSI high. So I've got a schematic, and hopefully everybody's screens are big enough that they can see the details here for colorectal cancer. So we start off with all patients that are under the age of 70. We do reflexive immunohistochemistry. If it's normal or intact staining, then if there's no family history, no further action, you will note that this program was not designed to replace the normal referral patterns into genetic, to see genetic counselors. If there is a positive family history, if there is concern based on family history that the patient has an underlying hereditary cancer syndrome, they should still be referred. And that is built into this algorithm at every step. If there's a positive family history, they should be referred. So if you've got abnormal immunohistochemistry, if you've got abnormal MSH2, MSH6, or PMS2, that is a direct line for referral to genetic counseling. The vast majority of those to be sorted out, they have a higher likelihood of having an underlying genetic change and really need to be sorted out in conjunction with genetic counselors. If the tumor is MLH1 deficient, for colorectal cancer, we have a two-step process. Tumors that have BRAF mutations are commonly associated with methylation and very rarely associated with Lynch syndrome. BRAF testing is the initial test that is done for patients that have MLH1 deficient colorectal cancer. It will pull out about 40% of those sporadic tumors. So if there is a BRAF mutation, again with no family history, we will assume that the likelihood of Lynch is low, and there's no further investigation that's needed. If BRAF is wild type, then we look at MLH1 promoter methylation. If it is hypermethylated, again with no family history, the likelihood of having a hereditary cancer syndrome is low. No further investigation is needed. It's only the tumors that are MLH1 deficient, BRAF wild type, that do not have promoter methylation that will actually be referred on to genetic counseling. For endometrial cancers, it's a very similar process. The only difference is BRAF does not play a role when it comes to the triaging of patients that have MLH1 deficient endometrial cancer. So if it's MLH1 deficient, it goes straight to methylation. So because that diagram can be a little tough to pull out, I've just pulled out the flow for colorectal cancer that are MLH1 deficient to make it a little easier to see. And again, it's the wild type that do not have hypermethylation that need to be referred to genetic counseling. And for endometrial cancers, it's just methylation testing. So, little summary there just written out to make it a little bit easier. So, when it came to implementation in Ontario, we started with 2 reference sites, and these reference sites were our current reference sites that deal with colorectal cancer. The reason they were chosen is because the bulk of testing when it comes for reflexive testing in the province is going to be related to colon cancer. They had the immunohistochemistry, BRAF, and methylation up and running. And so the reference sites in Ontario are UHN and Mount Sinai Hospital. We are opening up additional sites for BRAF and methylation this year. The first step that we want to get through was the implementation for immunohistochemistry. And I've got a listing here of all the current sites that are being funded for immunohistochemistry testing in Ontario. The majority of sites are happy to do the testing on both colon and endometrial samples. There are a couple centers that were only comfortable doing one or the other. So if you're taking a look at the sites and you're saying, oh great, I've got a nearby site that's doing immunohistochemistry, I want to go talk to them, just touch base with them to make sure that they're comfortable doing the stains on both samples. So there are some additional centers that may come on board because colon cancer, endometrial cancer are so common. We had a more complex process of reviewing biomarker test sites for immunohistochemistry. So we had a number of centers that we knew had the test up and running, and we wanted to try to onboard them early on. And then there were some centers that, when the new funding was coming, were more interested in really working up the immunohistochemistry and getting on board. And then so there will be a second wave of additional sites. So if you don't see your name in there and you said, hey, what's going on? It's just because the process is still ongoing. So I expect there will be a few more names added to this list in the next few months. So because we are dealing with Cancer Care Ontario and we are dealing with a funded biomarker, I can't do a talk without talking about synoptic reporting. So to be able to track what's happening within the province, to look at what's happening with regards to mismatch repair immunohistochemistry testing, and hopefully to eventually incorporate it into practice patterns, we do require synoptic reporting for mismatch repair immunohistochemistry. The immunohistochemistry is actually present in 3 different biomarker CAP templates that are in practice. I've got 2 key ones listed here. The first one is the biomarker testing for patients with colorectal cancer. It is also included in the biomarker testing template for patients with endometrial cancer. And of note, CAP also has a whole specific template for reporting of DNA mismatch repair as a separate template, and this is because of the association with checkpoint inhibitor immunotherapy, something that I'll talk on in a few minutes. So there are checklists that are available for CAP for use and should be done by all funded test centers. So I am not very happy with some of the wording, though, in the specific biomarker template that is there for in the colorectal and in the endometrial biomarker checklists. For the immunohistochemistry, there's no problem with the wording, it's nice and clear, but when it comes to the summary statements, if everything's got normal expression, low probability of tumors MSI high, that's fine. My issue has to do with the ones when you've got abnormal immunohistochemistry, when it talks about high probability of Lynch syndrome. Using immunohistochemistry alone and looking at the tumor, we cannot assess a patient for Lynch syndrome. That's within the domain of germline testing and the genetic counselor. So I don't like the wording, and while I use the checklist for the status of all the immunohistochemistry, I don't use the summary statement when there is a loss of expression. You do happen to use the checkpoint immune therapy or checklist. And here's the wording for the actual immunohistochemistry is also included on the slide, which is fine wording. You know, it talks about intact or loss. It just says that there's loss of expression of one or more mismatch repair proteins. There's deficient mismatch repair, which is perfectly appropriate. And so if you are using that checklist, it's fine to use the summary statements. But for the colorectal and endometrial checklists, I would avoid using the summary statements if you've got abnormal immunohistochemistry. So a few key points here. First of all, the immunohistochemistry is not a genetic test. As a result, we cannot talk about the germline expression. We cannot talk about the probability of a patient having Lynch syndrome. What we're really doing here is triaging and trying to identify the patients that should be seen by genetic services or by genetic counselors to see if there is an underlying hereditary predisposition to cancer. It's in their domain to actually diagnose whether or not a patient has Lynch syndrome. The reporting also has to be very clear. The wording on those checklists is fine. They talk about intact or loss of expression. We have to avoid terms of positive and negative. When pathologists get together and they talk about positive staining, to them that means that there is something there. Positive staining means that the nuclei are staining brown because the protein is there and being seen. When you talk to geneticists and you talk about a patient being positive for MLH1, MSH2, they assume that that means that there's loss of expression. It's positive. The patient likely has it. And there's more than one example where I've seen genetic counselors see a patient and they take the positive and negative and they flip how they interpret which genes could be involved. While we're moving to an era where you're basically doing panel-based testing, so you're testing everything, there are still some differences in the phenotypes of the different genes, so it is important to give a very clear picture to the geneticist as to actually what's happening on a phenotypic or molecular expression so they can appropriately counsel the patients. So this screening, and I forgot my air quotes here around the screening, is not a replacement for the referral pattern to genetic services. Patients with a positive family history still have a positive family history and should still be referred to genetics. There's other syndromes that are involved that pathology is not going to pick up with regard to hereditary colorectal cancer. We do have very rare, but there are some patients with Lynch syndrome that will have normal expression of the different genes. They're making either there's some of the other rarer genes involved in mismatch repair that are not being picked up, or they are making a gene that is sort of stable enough to hang around but is non-functional. Of note, there's no real role for doing just reflexive MSI on these cases because the number of cases that are MSI high with normal immunohistochemistry is extremely rare. So the screening is not a replacement for what's going on with genetic services. And it's important to recognize that we're all part of a clinical team. We need to have very clear communication, both with the clinicians as to what the phenotype is, what the underlying molecular biology of the cancer is, that we work with the genetic counselors for those fortunate enough to have genetic counselors on board. And it's certainly through some discussions with genetic counselors that some of the tougher cases end up getting resolved. I do have cases where the immunohistochemistry was difficult. We ended up having to either issue a questionable report, or there was some discrepancy between our findings and what was seen within the genetics clinic, and we can go back and make sure that any issues around interpretation or staining issues get resolved. So it's key that we're part of a clinical team if you're going to put this in place. So occasionally you get questions about the role for looking at adenomas within the screening program. And the quick answer to this is that there is no role for routinely staining adenomas when looking for Lynch syndrome. It's true that adenomas in patients with Lynch syndrome may appear at a younger age. They may harbor malignancy or be more high grade, but by testing adenomas, and especially just testing adenomas routinely in young patients, it does not give you any additional information. Even in patients with known Lynch syndrome, testing their adenomas, you're going to find something abnormal in only about 50% of the cases. So it is not a reliable source. There's no role for doing it as a routine part of screening. I will occasionally do adenoma testing, particularly for genetic counselors in situations where they've been referred a patient, so there is a underlying at least increased risk for the patient having a hereditary syndrome with predisposition to colorectal cancer. Typically, they do not have any access to an invasive colon cancer or other Lynch syndrome associated tumor that would give them more information. And I put in with the caveat that if it's abnormal, then you have something to work with, because now you know that there is some abnormal expression. You can investigate something and try to interpret what it would mean. If it comes back normal, you're no further ahead. It does not exclude the likelihood that the tumors associated in that family are MSI high or associated with Lynch. So now, should you be in this situation, you're talking to a genetic counselor, you are doing staining on the adenoma, you will come across situations, and I apologize for the pale staining here, where you can see clear loss of expression within the adenoma. For those that look at a lot of these, I'll also mention that there's a recent paper where there's talk of seeing abnormal expression in adjacent normal mucosa to tumors or to adenomas, and in those situations there being a higher likelihood of the patient having an underlying Lynch syndrome. So it can be done, but I would not do it as part of a routine process, and it's only done in conjunction with clinicians that really understand the role of interpreting immunohistochemistry or MSI testing on adenomas. So we've talked about MSI testing in conjunction with Lynch syndrome. For colorectal cancer in particularly, there's an increased request for doing MSI for clinical purposes, and there's two key reasons for doing that. The first one is that MSI or abnormal mismatch repair immunohistochemistry is a prognostic marker, and patients that have tumors that are MSI high, stage for stage, have a better prognosis. When looking at patients with stage 2 colorectal cancer, there's good evidence to say that tumors that are MSI high will not benefit from adjuvant chemotherapy. If you look at the colon cancer pathway put out by CCO, it actually mentions about doing MSI as one of the risk indicators for patients with colorectal cancer. And the oncologists at Mount Sinai Hospital have been using MSI to help to select which stage 2 colorectal cancer patients they would consider for chemotherapy for a number of years. So it is a prognostic marker, and it can be used to help stratify patients with stage 2 colorectal cancer and determining which patients should be targeted for adjuvant chemotherapy. So this is just a survival curve showing that all tumors that are MSI high have improved prognosis, and that can be broken out by stage. So stage for stage, tumors that are MSI high have a better prognosis. The other role for mismatch repair immunohistochemistry MSI testing is as a predictive marker. Now this was very interesting a number of years ago when this study was put out by the New England Journal. Now, it was a retrospective study. It looked at single-arm chemotherapy, which is not the standard chemotherapy being used today. But basically, the top graph shows that patients that did not receive chemotherapy and tumors that were MSI high had a better prognosis than tumors that were stable. And the bottom graph shows the patients that received chemotherapy. And you could see that the benefit from having an MSI high tumor sort of disappeared. So there's concern that the patients that had MSI high had no benefit from chemotherapy. And in fact, when you separated it out and you just looked at the top graph here are tumors that were microsatellite stable, you gave adjuvant chemotherapy, a little bit of benefit against no adjuvant chemotherapy. When you took out tumors that were just MSI high, no chemotherapy actually did better than patients that received 5-FU alone. So if for some reason an oncologist is considering giving 5-FU alone as part of chemotherapy, it is not unreasonable for them to ask for MSI status, because there is some evidence to suggest that you will be doing no benefit and potentially doing harm by giving 5-FU alone to an MSI high tumor. There's been a lot of follow-up studies looking at the role of MSI as a predictive marker, and a lot of clinical trials will actually stratify their patient population based on MSI status. So it is not rare now for clinicians to be routinely asking for MSI status, not only in their stage 1 patients, in the patients with stage 2, but in patients who are stage 3, particularly if they are being considered for clinical trial. The other area for colorectal cancer where you're routinely going to be asked for MSI status is as a predictive marker for immune modulating therapy. If you noticed, the checklist that was specifically pulled out for mismatch repair immunohistochemistry. It was related to checkpoint immune modulating therapy. In the U.S., the FDA has approved for the first time treatment totally based on a molecular phenotype, and that is any tumor in the U.S. that is MSI high is eligible for immune modulating therapy. Now, that is not the standard of care right now in Ontario, but for patients being seen by oncologists that are considering clinical trials, or where they have access to immune modulating therapy, the patients that are going to respond are the MSI high tumors. So it is not uncommon now for oncologists to be asking, in addition to our ERAS for MSI status, to determine the best potential therapy for patients with metastatic colorectal cancer. So basically, for Ontario, what that means is we are currently looking at MSI testing on all colorectal cancers in patients under the age of 70, on all stage 2 colorectal cancers, and on all metastatic colorectal cancers. So now, where are we going with MSI status within the province? As I mentioned, the immunohistochemistry right now sort of functions independently from the way genetics runs out into the province. And in fact, genetic testing and genetic services as a program are still under the direction of the Ministry of Health in Ontario. So by putting in place a reflexive immunohistochemistry testing program, one of the things that we need to look forward is how does this integrate with testing that's being done or requested for genetic counselors, so that we can ensure that the genetic counselors are getting the results that they need to appropriately counsel the patients. And when patients get referred to genetic counseling, any testing that is done is rolled into either part of an overall provincial program around mismatch repair or MSI high testing. So we're looking at how do we integrate this with genetics. The other part about doing this in Ontario is looking at closing the loop. The patients that do go on to be referred to genetics, how do we ensure that we are seeing the appropriate germline testing? How do we look to see if our screening program is actually picking up, increasing the likelihood of finding patients with Lynch syndrome? And how do we ensure that patients with Lynch syndrome are moving on to the appropriate screening programs? So the future direction is really to integrate the testing into genetic services, integrated into a high-risk colorectal screening program, and to look at the outcome from germline testing so that we can start correlating the immunohistochemistry finding, referral patterns, and germline findings to make sure that patients are receiving the appropriate care. The other part for direction is incorporating clinical mismatch repair immunohistochemistry testing with the screening testing. Currently, while we are funding mismatch repair, Cancer Care Ontario is funding mismatch repair immunohistochemistry for reflexive testing on patients under the age of 70, clinical mismatch repair testing is outside the funding envelope. So we are expanding the capacity within the province to do MMR testing, but there is this bit of a funding gap that needs to be closed to ensure that mismatch repair testing is available for all patients where it is needed. When you look at the number of disease sites involved with Lynch syndrome, and you look at our current testing algorithms, we really focus in on the most common, colorectal cancer, endometrial cancer. There are other tumors that are associated with Lynch syndrome, where in the appropriate situation, immunohistochemistry would be appropriate. Again, this is outside our current funding envelope, but it would be ideal to expand the number of tumors where reflexive testing is done or targeted testing is done to further pick up the potential families with Lynch syndrome. An obvious example for this one has to do with sebaceous tumors. Patients with Murray-Thor that present with sebaceous tumors, which are rare, can be associated with MSH2 germline alterations in Lynch syndrome, and can be detected very reliably with immunohistochemistry. So ideally, we'll expand the number of disease sites. We'll have immunohistochemistry-based testing. And the other thing that we have to consider is that as tumor-based testing moves to larger and larger tests, panel-based tests, which could include looking at the actual gene, underlying genetic changes within the mismatch repair genes, such as looking at MLH1, MSH2, MSH6, PMS2 as part of a panel when we do RAS testing, and looking at a molecular algorithm for picking up MSI testing as opposed to doing a separate molecular test. How does expansion of panel-based testing fit with the mismatch repair expression? This will become more and more relevant as in Ontario we are moving to tumor-based testing, where we try to do comprehensive testing around disease sites as opposed to focusing on molecular markers alone. So I've got just a couple last slides that have to do with the expansion of indication. And occasionally, I will say that at Sinai, we are very aggressive at the tumors that we do mismatch repair immunohistochemistry on. Because we're tied into a genetics clinic, we get a lot of referrals from geneticists. And my basic rule to the geneticists is, if the testing is going to impact how you counsel a patient or impact patient management, we will do the immunohistochemistry. And this is just an example from a breast cancer case, and just with, again, I believe it's MSH2, and you can see that it follows the same sort of rules that I use for endometrium and colon. You've got good staining adjacent stromal tissue. You've got absent staining within the tumor. And the immunohistochemistry works really, really well on a wide range of tumors, a wide range of sites. And we've used it, like I said, in a number of different disease sites with quite high reliability. So I'm going to leave it there, and I will open it up for questions.
Thank you, Dr. Pollett. I'm happy to read any questions that come in. You can type them in the chat box on the left on Skype. Okay, our first question is from NSHA. Do you have a sense of how many labs use 2 versus 4 stains?
Okay, yeah, that's a common question. I do know that out in BC, the main testing lab there actually uses the 2 stain method. For those that are wondering, because we've got a dominant pair situation, the literature does support the idea of just doing an initial staining run of MSH6 and PMS2, and if those are abnormal, then you do MLH1 and MSH2. My sense, just on some conversations that I've had, is that of the centers that are routinely doing immunohistochemistry, there are 2 centers that do 2 stains routinely, and then we'll just reflex to the 4 if need be. The other stains are using the other centers are using a 4-stain method. I prefer doing the 4-stain method just because it gives me a good sense of what's going on within the tumor. If there is a difficult case, which, you know, when you do enough of them, you will come across them, it gives me more confidence in helping interpret those difficult cases. I don't see any problem with a center that really wants to use just 2 stains. From doing an awful lot of immunohistochemistry, it's very rare that you will find something that will fall outside of the normal staining pattern.
Okay, thank you. The next question is from J.K. McDonald. Will you comment on informed consent and the CADIF 2016 review?
Yes. So I specifically did not put that in the presentation because I needed to have something to fill up any question time that could come by. So this is a very interesting issue. Consent was certainly something that was talked about a lot when immunohistochemistry came out and was initially being done. A lot of the early wording and some of the concerns that I have with the checklists that are actually put forward have to do with the idea that you are essentially making a diagnosis of a genetic syndrome based on an immunohistochemical finding in a tumor. Our understanding of mismatch repair, gene expression, the finding of a lot of somatic changes, including somatic biallelic changes in MSH2, have really helped establish the fact that the tumor findings are not germline, which has allayed some of the concerns around informed consent. Now, that being said, and I do know that your specific issue has to do about a formalized bioethics review on informed consent. When we initially were looking at developing a position paper on the use of mismatch repair immunohistochemistry and MSI testing in Ontario, we had reached out to a bioethicist in Sunnybrook. Their opinion from the bioethics was that informed consent was not needed. That was not a formalized review. Looking through the literature, there's not a lot of large bioethics formalized review. The largest one that you've got, and that you mentioned specifically, is the CADIF report that came out in 2016. One of the issues I have with the CADIF report is when you read the summary report and then you go back to the actual ethics document that was created, there's one line that came out in the report that was not in the actual ethics document itself. The ethics document itself, as a lot of ethics documents, can be interpreted any which way you want, depending on how you want to read. It's great at putting out the issues. It does not come to any particular conclusion about whether or not informed consent is needed or not needed, specifically when it's related to Lynch. Now, that ethics document, when the CADIF summary document came out, they put in a line about consent. I can't remember exactly what the wording is, but they imply that consent could be needed if you are doing it with the intention of identifying patients with Lynch syndrome. Okay, so somebody took the ethics report and interpreted it in a way that is not specifically there in the ethics report. Now, given that discrepancy, we've actually gone out, we've reached out to CADIF to talk to the original authors of the ethics document, to talk to them in the context of, guidelines that have since come out in the US with regards to universal testing on colon and endometrial cancer without the need for informed consent. Given the fact that in 2017, legislation actually came out to around protecting the use of genetic information in Canada. Canada was a little bit late to the game at providing such legislation, but it is in place now. Those two documents were not in place when the ethics review was done. And the other thing that I would like to really discuss with the authors from that ethics review is they talk about a lot of theoreticals, and they say that in theory, if identifying patients would prevent colorectal cancer, my argument is that the literature seems pretty clear that by identifying the families, you will prevent colon cancer, if that would change how they would see the use of, reflexively identifying these families. So they haven't gotten back to us. We've gone after the authors of the original document, and if we have to, we'll escalate that through the CADIF hierarchy.
Okay, thank you. And the next question is from Jennifer Christensen. Why was a cutoff of 70 years old chosen? You may potentially miss 10% of Lynch cases that occur in patients greater than 70 years old, specifically colon.
Yeah. So some of that had to do, and it comes down to a economics argument, and identifying the patients, getting them into a screening program, preventing colorectal cancer, and some of the documents that came out a number of years ago on the health review. Once you get past the age of 70, because colorectal cancer in particular becomes so much more common, the number of sporadic cases that are MLH1 that you're picking up that involve having to be worked up and potential noise increase the cost for picking up patients with Lynch syndrome. So the decision at the time when we were reviewing it is, as that seemed to be the inflection point at which the costs increased, we would use 70 as the cutoff. We do recognize that you are not picking up 100%. None of these programs will pick up 100% of Lynch syndrome, but we are potentially missing patients with Lynch syndrome by in putting in this cutoff. Centers are certainly welcome to expand the testing in their situation. And we are also hopeful that if the patients truly have Lynch, we are not replacing the current mechanisms that exist. If a patient's older, but they have family history and there is enough of the other clinical criteria to warrant referral to genetics, we are certainly hoping that the patients will still be referred. So we recognize that there were some cutoffs, and it was largely economics that led to that decision. And it's something that once we have this in place, it's up and it's running, like all our biomarkers, what we do is we end up with communities of practice. It involves all test centers, clinical leads. Here we would also involve leads or connections in with the genetics community, and we review the current clinical criteria that we're using to see if it's warranted to expand the age cutoff. I'm just going to mention one other thing here, and that is when genetic services are still funded by the ministry. We are working and looking at genetic services within the province. And in Ontario, we've done a couple surveys where we've looked at staffing needs, referral patterns, and it's pretty clear that there is insufficient capacity inside Ontario to fit the need for genetic counseling. So before we would expand potential testing, which would increase the number of sporadic cases that would still need to be sorted out by genetic services, I'd like to make sure that we've got some mechanism to help support the genetic services in place so that they're not swamped by cases with a low likelihood of Lynch syndrome.
Great, thank you. The next question is from Hamilton Health Sciences. Should we be routinely sending all our MLH1 deficient cases by IHC for MLH1 methylation?
Yes.
Okay, great. Next is from McGill. How is BRAF testing performed at your center? Is it with IHC?
We do molecular testing for BRAF. There are centers, and again, BC has routinely does a BRAF by immunohistochemistry. In Ontario, the funded BRAF testing that we've put in place for all the BRAF testing has been molecular in nature. My read of the literature and the read at CCO was that the immunohistochemistry seems to be one of these ones that when it works well, but it doesn't work well all the time. So you still need to have some molecular backup. Some of the papers with BRAF immunohistochemistry are really wishy-washy, where they basically do the immuno and then do molecular on everything and then say how good their immuno was, but they're only confident in reporting the molecular. And we also had some conversations. It just happened to be that Wade Samowitz from ARUP came up a number of years ago and gave a talk. He's been heavily involved with mismatch repair, molecular testing on colorectal cancer, was the reference center for Ontario for doing promoter methylation until it came into the province. He was on a team that actually worked and developed the initial BRAF immunohistochemistry, and he says he's actually got his name on patents and gets royalties and so on for whatever. But in his site, they elected to stay with molecular BRAF testing just because they were more confident in the results that would come from molecular testing than the immunohistochemistry alone. So our approach has been to maintain molecular testing for BRAF in Ontario.
The next question is from Amir from William Osler, Brampton. I have seen cases of colon carcinoma with loss of MLH1 staining in more than 90% of invasive carcinomas, but deeply seated tumor cells show intact MLH1 by IHC. Have you had this experience? How would you report it?
Yeah, okay. So I'm trying to visualize this particular case, and I'd have to actually see it to know exactly how I would report it. But you were talking, for purposes of this talk, when we talked about abnormal immunohistochemistry, we said 100% loss. The reality is, when you do enough cases, that is not the way it's going to be. When we did a validation study with Hamilton, and I've really got to shout out to Alice Litwin, who's very good at talking about methodology and didn't let me talk about, well, you know, with the bulk of the tumor, if it's very clear that the tumor was abnormal, just because you look at a bunch and that one's clearly abnormal. She really had us sit down to talk about some sort of percentages. And if the number that we sort of came up with is that you really need to see abnormal, and I'm not talking about you go through and you actually count cells, but you would see abnormal staining in at least 90% of the tumor. It would be regional in its distribution. So it's not scattered abnormal staining. It is a clear-cut area of tumor abnormal expression. And the tumor that you're assessing has to have good staining in the adjacent normal mucosa. I didn't have time in this talk to go through a host of my difficult immuno slides. That's like a whole talk unto itself. But my approach is if I've got really good staining in adjacent normal tissue and clear absence in a region of the tumor, that's abnormal. So the way I get around that, if I've got some things that are difficult to interpret, and it's not just, hey, I've got a few tumor cells staining here and there, where I'm going to call it abnormal loss and so on, is I report it as being abnormal. That is enough to have the patient appropriately referred to genetics clinic to get things appropriately worked out for potential Lynch syndrome. It is a little bit trickier in the context of therapy. Now, I will tell you that when I've microdissected out tumors that have this sort of abnormal zones of abnormal expression and zones of intact expression, the microsatellite pattern fits with the immunohistochemistry. So if you've got good quality immuno, you've got clear loss of MLH1 in a zone of that tumor, I would call it as abnormal, and that zone of that tumor would be MSI high. You know, if you're not sure because it's wishy-washy and washing in and washing out, you know, one of the things I'd recommend is repeating the immuno on another block, or potentially sending it to another site to see if they're finding something similar. And if you're really stuck, just calling it either abnormal or equivocal with a description.
Thanks. The next question is from Janice Webster. Should pathology labs be notifying genetic counseling clinics about patients with abnormal MSH2, MSH6, or PMS2 by IHC in order to help ensure that these patients are referred to genetic counseling?
Thank you for bringing that up. It's something that I meant to put in my slides. Part of any of the funded centers in Ontario have to specifically outline how they are connected into the genetics so that patients where the testing is done get the appropriate referral, so that there is some sort of note that goes with the staining that has, especially staining where you've got abnormal, you know, MSH2, MSH6, PMS2, where patients should be referred. So there is standard, there is a communication that should go on any path report that with the abnormal expression that the patient should be seen with genetics. And the eventual goal and the integration in with genetic services is hopefully we'll eventually have that, close that loop to ensure that patients that have the abnormal immunohistochemistry actually either get referred or show up or have some sort of patient navigation to ensure that the patients that should be seen by genetic services are seen by genetic services. So yes, it's very important that you close the loop and get the patients with abnormal expression into genetic services.
Great. Our next question is from Jennifer Christensen again. Would you recommend screening patients greater than age 70 using Greenson histologic criteria, and then testing for MMR if screening suggests a significant risk?
I would say that if you're really looking to expand and pick up additional cases, that you just do the immunohistochemistry on all colorectal cancers. In an ideal world, that's exactly what we would do. If you've got the genetic services that can support that initiative, especially if you're in a local situation where you're testing your own patients, you're tied in tightly with genetics and you could test all the patients, I would do that. Any sort of histologic criteria that I think that you would put in place, you're going to pick up tumors that are MSI high. I'm not sure that you're still going to capture all your Lynch syndrome patients without testing everybody.
Okay, and we're on our last question from HS. With large resection specimens, suboptimal fixation can affect quality. We are now getting scout sections ASAP. What is your experience?
Yeah, you know, we are lucky that this immuno tends to work out relatively well, even on some samples that don't have great fixation, and we don't have to quantitate it. So we're not in the world of ER, PR, and HER2 where fixation can just be absolutely awful. Now, that being said, the quality of the immuno is better on the quality of the specimen. Occasionally, when I've had samples that have not been fixed well, which thankfully are relatively rare now, most centers are very good at fixing the sample, I have had to go after either a biopsy that was done ahead of time. The immunohistochemistry works really well on a biopsy, or I do end up having to take a look to select an area tumor that's got better fixation. If you've got some scout sections or you've got something where you are specifically ensuring you've got areas that are better fixed, then that's the area to target to get the best possible immunohistochemical outcome. Now, occasionally, if the thing is really not been well treated, has not been well fixed, and you've got crappy immuno, you basically have to report it saying, hey, I can't interpret, and here's all the reasons why. And if you need to find out what the status is, you can try molecular, which might still work even if the immunohistochemistry has not been expressed, but you're way better off trying to just ensure that you've got well-fixed specimens so you can do the work that you need to do.
We got one more question, if that's okay.
Sure. Yeah.
This is from Melissa Hickey from Horizon, New Brunswick. We perform MSI IHC on resection rather than the biopsy specimens unless otherwise asked by our oncologists. Do you think one is better than the other?
Either one works well. In BC, in Victoria Hospital, they routinely do it on biopsies because they found the fixation was better. If you've got a good tumor sample, the biopsies are perfectly fine for immunohistochemistry. So you don't need to wait for the resection. And I would even think that, in particular for endometrial cancers, that doing the immunohistochemistry ahead of time can sort of plan some of the pre-op decision making, especially if you happen to be fortunate enough where you've got good ties in with genetics and potential rapid genetic assessment on patients that could have Lynch syndrome, because you don't want to do, depending on patient's age, obviously, and situation, but patients with Lynch syndrome are not the ones to consider ovarian sparing surgery. And there are also patients that you might want to consider doing colonoscopy ahead of doing any sort of endometrial operation, because you'd hate to miss a silent colon cancer at the time that they're doing surgery.
Thank you. Those are all the questions that we have. Oh, sorry. One more question from Terrence. Thanks for a great presentation, Aaron. When are you coming to Bell's Corners?
Hey, hopefully I'll be up there sometime soon.
Okay. Thank you, and I'd like to turn it over to Dr. Strigley to close our session.
Thanks, Shelley. So on behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I'd really like to thank Aaron for an excellent presentation on a very timely topic. As a reminder, both the live and recorded presentations are eligible for CME credits. In order to obtain your certificate of participation, please provide your name and email address at the link included in the session notice. Here you will find the optional session evaluation form, which we encourage you to complete as well. The information collected through the session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your comments and suggestions. Please note that the next session is actually next Wednesday, February the 27th. It's going to be on testicular tumors, advances in WHO classification and TNM8, and it's going to be given by Dr. Asla Yilmaz from the University of Calgary. Thank everybody for attending, and we'll see you next week. Bye for now.